Yeah, I have a few slides here.
Okay. Shall we start with you? Nuraj, you also have few slides, huh?
Yes, sir.
Yeah, so we'll start with Siva, and then we'll take up your slides, and then Buddhika will be presenting the cases.
Okay, sir.
Fine. I have about I know I said about 5 or 6 slides product very but I'll go through them quickly.
It's okay, we have time.
It's better to have a few terminology and things so that
that's okay. Yeah.
Context.
Yeah.
Yeah.
So we'll wait for about 2 more minutes and start.
Sure. No problem.
Okay.
Yes, great project for the month of February. Today's topic, today we will be discussing about the management of colorectal cancer liver metastasis, the surgical perspective and the oncological perspective. So unlike the previous webinars, this time 2 experts will be joining with us, representing Sri Lanka College of Clinical Oncologists, Dr. Nuraj Joseph, clinical oncologist from General Hospital Hambantota, and representing the GI surgery, Professor S. Shivaganesh, consultant HPB surgeon who's attached to National Hospital Professorial Surgical Unit. And also to bring up the cases for the discussion, Dr. Buddhika Urakoda is acting GI surgeon who's attached to Teaching Hospital Kalubowila. So shall we start with Siva? What we'll be doing is, first of all, we'll be just having brief introductions about basic oncological and surgical principles in management of colorectal cancer, liver metastasis, and then we will, after that, we will be moving on to the discussions. So shall we start with Siva?
Okay, thanks, Rohan. So let's make this as interactive as possible. I'm just going to give a brief overview of the surgical perspective, as Rohan said, and I would be glad if anybody, including the panelists or the attendees, would like to join or make any suggestions, observations as we go along. Okay. I'm allowed to share, right?
Yeah, you should be able to share.
Let me get that. You all can see that, right?
Yes, we can see, yes.
Okay, right. So very briefly, why is this important? We all know that it's one of the most common cancers globally and accounts for nearly 25% of all cancer deaths. And about a quarter of patients present with stage 4 disease at diagnosis, and the majority of these, of course, are confined to the liver. So that's why colorectal liver cancer metastasis, that's why we are talking about this problem, because it's very important, as you can see. Just a few things about definitions. And in 2015, the consensus group globally met on colorectal cancers, and they defined what a metachronous and a synchronous colorectal cancer metastasis is. And they've divided them into early and late metachronous based on whether it's in the first year or after the first year. And a synchronous metastasis, of course, is one that is detected at or before the primary colon cancer or rectal cancer is diagnosed. And these are not simply arbitrary definitions. They are related really to outcomes and prognosis, as we will see. And this is probably the most important message we want to convey here. And that is, surgery is the most effective and curative option for colorectal liver metastasis. And there was this large registry that went on for about, if I'm right, 24 or 25 years, where they looked at what happened to untreated colorectal cancer metastasis. And as you can see, the survival was really bad. 1 year survival when you had liver metastasis was just 1 in 3 or 30%. And by 5 years, less than 5% of these patients were surviving. So it goes to say that surgery has actually revolutionized outcomes in colorectal cancer, liver metastasis, really. And in terms of prognosis, it's now fairly clear that if you have synchronous metastasis, your outcomes are likely to be poorer than early metachronous and later. So basically, the time lag from the primary to the appearance of liver metastasis has an impact on prognosis. Having said that, that should not preclude aggressive treatment of colorectal liver metastatic disease, because as we've seen again, it is curable. Coming out of this consensus meeting, and I would suggest anyone who's keen to have a look at this paper that came in Cancer Treatment Reviews, where they've summarized all this. These are some of the treatment priorities that they've identified. And it's still fairly well established in most centers that high quality CT is a very important investigation prior to chemotherapy. That's important. And this high quality CT is something that I think even in this country we should standardize, and our radiologists should probably look at making sure that this is done, because it's very important in terms of planning therapy in these patients. MRI is still used. It's still recommended in difficult situations, sub-centimeter lesions. The other important aspect is radiology reporting. So we need to make sure that we have all this information that's up there: the size of the nodules, which segments, the relationship to vessels, anticipated liver remnant volume. All these are key requirements for good outcomes in colorectal metastatic surgery. And of course, pathologists have a part to play in this as well. And so these are some of the key management consensus principles, the overarching principles that determine how we manage colorectal cancer liver metastasis. And you can see the first statement by itself tells us that there is no one size fits all. The treatment strategy largely depends on the clinical scenario and the context. And by context, it means not only the site of the lesion, it means the expertise, the availability of resources, the clinical experience, and patient-related factors. So it is variable, and you will see difference in patterns of management of colorectal liver metastasis in different regions of the world. So if you look at the European subcontinent and South and Southeast Asia, the threshold for doing certain things is different. So there is an element of cultural and regional difference in how these are managed, but these broad principles are applied. And in many instances, what they would recommend in these patients is chemotherapy before surgery. I'm sure Nurad would talk more about that. When the primary colorectal cancer is asymptomatic, there is a tendency to move towards the reverse approach of the liver first surgical approach. The conventional traditional approach has always been to do the primary, followed by either the hepatectomy or a bout of chemotherapy and then liver. But this has changed significantly. When there are unresectable liver metastases, it makes always sense to downsize the tumor with chemotherapy and then consider for resection. I think the very important part is the last principle, and that is always consider resection for stable disease. Even after optimal chemotherapy, if your disease is stable, that patient should be offered liver surgery, provided, of course, there is an adequate liver remnant at the end of the day with the inflow and the outflow to the liver. So that is a key principle, and I think all liver surgeons know it's when we talk about liver surgery, yes, we, apart from oncological margins, what we really want at the end of the day is an adequate volume of liver which has inflow and outflow. It's more about what we leave behind than what we take out in terms of outcome. This is just to give context in terms of when we talk about hepatectomies. These are conventional segmental resections. And generally, we talk about major and minor hepatectomy. The major hepatectomy is when we talk about removing 3 or more quina segments of the liver. So, for instance, segment 2, 3, and 4 in a left hepatectomy would be a major resection, whereas just taking only segment 2 and 3 out is considered a minor resection. Now, the minor and major in these resections is not necessarily linked to the complexity of surgery. You can have a complex minor procedure and a not so complex major resection. It mainly relates to the residual liver and the alterations in physiological adaptations that may occur due to the remnant of the liver, and that's what really determines when we is referred to when we talk about major and minor resections. So to put it in perspective, and this is what again we want to stress, and I'm sure Rohan and other surgeons here, is that we have many more tools in our kit to deal with colorectal liver metastasis. Considering over the past 4 to 5 decades, there's been a significant evolution in surgical technique, in strategies, and in terms of equipment we have to deal with colorectal liver metastasis. And this is why we would like all of us who work in this field to, wherever possible, adapt an aggressive approach to try and give these patients a chance so that we may ensure that there is, they get the best available option with an intention to cure. Treatment strategy, and these are some of the factors we need to consider when we decide on how we go about treating these patients. We've got a primary and we've got a secondary, and this is especially so for synchronous lesions. One is where is the primary? Is it in the right colon or the left colon? And if it's in the rectum, is it the upper or lower rectum? And whether the primary is symptomatic, for instance, is it bleeding or obstructing, or there is impending obstruction, or whether it's part of a perforation. The next important thing is about the met itself, the size, the distribution, and the involvement of vascular structures. And not forgetting, of course, the patient him or herself, their ASA, metabolic score, performance score, and the quality of the underlying liver, a very important determinant in how these patients will fare after resection. So these are important factors to consider. And for good outcomes for malignant disease after liver resection, we want to have an oncologically sound R0 resection. So that's fundamental. Having said that, like I said, we need to have an adequate liver remnant with inflow, biliary drainage, and outflow. That's mandatory. You may do a good resection, take out all the tumor, but if the second condition is not met, your outcomes are not going to be good. The most serious post-operative complication that liver surgeons fear is this, it's post-hepatectomy liver failure. And it is to address this problem that we have now, we have many tools at our disposal and strategies. And these strategies are primarily targeted at reducing or minimizing the chance of post-hepatectomy liver failure. And you can broadly classify, there is some overlap as well, them into those which require parenchymal preservation, or those that lead to parenchymal preservation, and those that actually lead to parenchymal proliferation or enhancement. I'll briefly look at those. So if you are talking about parenchymal enhancement, one tool, and this is where our colleagues in interventional radiology come in, is preoperative portal vein embolization, which you embolize the vein of the segment of liver that you're going to remove. Usually this is done in cases of where we're going to do a major right lobe resection, an extended right hepatectomy. And the other one is called ALPS, where there is a combination of liver resection and portal vein ligation in the first stage, and then you do a second stage where the tumor is, or the hepatectomy is done. I'll briefly touch on that later. And there are strategies to spare parenchyma. So we've started moving, and more liver surgery is moving from the conventional or the traditional segmental resections to non-anatomical resections and metastasectomies. Now, there was some concern initially whether this is oncologically sound, and there is now enough data to say that this is indeed the case. Additional tools in our box are the ablative therapies that we now have, microwave and radiofrequency ablation, and two-stage hepatectomies can be used in certain selected and challenging situations with bilobar disease. So this is what I briefly touched on. ALPS, where in the first stage there is a transection of the parenchyma and ligation of the portal vein, leaving the, so this will be the future liver remnant. If there are any tumors, non-anatomical resections of the tumors are done in the residual lobe. And after a period of a week to 10 days, the liver is reassessed for hypertrophy. And then the second stage is where the right lobe or the large segment of the liver comes out. Ablative therapies, as I told you, we've got radiofrequency ablation and microwave ablation. These are done percutaneously, but very often we use this now in combination with surgery. So it's done intraoperatively under ultrasound guidance. They are very effective for small tumors, deep-seated tumors, and they are one of the key tools that help us as liver surgeons from removing too much parenchyma and accessing deep-seated small metastases. What size? Generally 2, maybe 3 centimeters, because you need a penumbra of an ablative zone around. Newer probes can go up to about 5 centimeters, but I think to be comfortable, we wouldn't probably go to ablate things above 2 or maybe 3 centimeters. The other strategy is doing a 2-stage hepatectomy, where you have bilobar disease, which is not resectable in a single stage. And you usually go for the minor resection or metasectomy in the future liver remnant. At the same time, you can go ahead and ligate the contralateral portal vein or do a portal vein embolization maybe before that. And you allow a period of regeneration, usually 3 weeks, chemo, and then you do a second CT and see whether you've got an adequate remnant and a resectable right lobe. Of course, a fairly significant number of patients in this group may not actually end up in the second, or not have their second procedure, either because the tumor has progressed during this period or the future liver remnant has not adequately hypertrophied. But it's still a strategy in that we can go about. So we have moved away, as I said, from this concern. So here you see a patient who's got a massive right lobe tumor, just segment 2 and 3 are free of tumor, but it's good liver, so we are able to do an extended right hepatectomy and take out this tumor. But we are moving away from these to what we call parenchyma sparing surgery or metastasectomies, non-anatomical liver resection. Here is a patient who had 10 metastases removed, and you can go around with intraoperative ultrasound, and in combination also where necessary radiofrequency ablation, you can take out large amount of metastases, and this is for bilobar disease. These are the new tools and strategies and for patients with colorectal metastasis, where you can attempt here. And in some instances, you can go for 1-stage procedures. We'll be talking about that as we go, where you can resect the primary and do a hepatectomy in the same setting. Of course, the risk of morbidity and mortality is high, especially if these patients have got the comorbidities. And as a general principle, what we would do is not really combine this with rectal surgery, but you may combine a minor hepatectomy with a complex colonic resection, or a major hepatectomy with a standard, or maybe usually a right colonic resection. Beyond that, there are maybe a few centers that do more extensive work, but it's probably may lead to more morbidity and mortality. So I think that's all I have to say for now. Rohan, if anyone wants to have any questions on this, they can ask, or I think we can move on and ask Murad to give his.
I think we'll leave the questions to the end. I think we'll move to Murad's presentation.
Okay, thank you, sir, and thank you to the thank you for this opportunity to speak about colorectal liver metastasis from a clinical oncologist perspective. Now, in oncology, we approach every patient with this. Our first question is this curative or palliative? And as you listen to Professor Sivaganesh's talk, you would have realized that this is a scenario where the actual demarcation between cure and palliation is a bit blurred. So we would certainly approach this with curative intent as far as possible. As he very correctly said, for patients with metastasis confined to the liver, we need to approach them with a more aggressive approach. So lots of unresolved questions. There is no sort of flowchart approach here. You have to weigh a lot of factors. We don't know. We talked about doing surgery to the liver and the primary, where how do you sequence chemotherapy, and in rectal cancer, how do you sequence surgery, chemotherapy and radiotherapy. So there is no sort of evidence-based approach to guide us. And for the reason that these cases are highly complex and individualized, and we need to make a personalized decision based on each patient. So the first thing to say is that every case should be discussed at MDTs. Now we say that for all cancers, but in no other situation is it more important than in a patient with a colorectal cancer and a liver metastasis. We need to sort of agree on sequence of treatment, timing, and our subsequent management. It's also Professor Sivaganesh spoke with the characteristic zeal of a surgeon, and he talked about going for aggressive treatment, and I fully agree with that. But it's worth reminding ourselves that I will show you the data later on, that even in well-selected cases with resectable liver metastasis, the 5-year overall survival is 50%, and if you look at disease-free or progression-free survival, it's around 25 to 30%. So about half of our patients would, nearly 2/3 of our patients will progress despite our aggressive treatment. That is not a reason not to offer treatment. We absolutely must do that. But it's something to keep in mind when we weigh the individual factors in deciding the management of each patient. So he talked about prognostic factors, and I will just skip this a bit. The first question is, do we need to do a PET CT for patients with liver metastasis, liver-only metastasis? Now, if the patient has sort of anything more than resectable, sort of the borderline resectable and certainly unresectable liver metastasis, and we're considering a curative approach, I think we would need to do a PET CT if available to rule out any extra hepatic metastasis. A randomized controlled trial was performed in resectable liver metastasis, and they found that there was no overall survival difference. But it changed the management in 8 patients, either previously deemed metastasis were subsequently subsequently determined to be not metastasis, or it was upstaged. So the NCCN guidelines, as well as the guidelines of the Royal College of Radiologists, do recommend, in spite of this trial showing no overall survival advantage, they do recommend performing a PET-CT if available, as it would change the management in 8% of patients. You might think that that's a small number, but for oncologists, I think 8% is a big number. We give chemotherapy and lots of fancy treatment when the survival gains are just around 4 to 5%. So if it is changing the management in 8% of patients, I think I would certainly support doing a PET-CT if available. The inability to do one should not deter you from proceeding with curative intent treatment. So in our setting, we have two centers with PET-CT, and I think these patients should be prioritized because it would impact on the management. There are lots of systemic treatments available. We've moved on from the conventional chemotherapy 5FU, capecitabine, oxaliplatin, and irinotecan to more targeted approaches, primarily the anti-vascular endothelial growth factor receptors, bevacizumab, first line, and then aflibercept, a limited indication actually. It's actually indicated in patients for second-line treatment of patients who did not receive bevacizumab, and then ramucirumab again in the second-line treatment. Immunotherapy is being used for patients with mismatch repair deficiency. Again, however, in the curative setting, the evidence is unknown. The anti-EGFR agents, cetuximab and panitumumab, again, our use is being restricted now to left-sided primary tumors, which express, do not express RAS and REF mutations. So we'll be talking about these as we go along. And finally, as a last line treatment, we have the multikinase inhibitor regorafenib. So Professor Sivaganesh talked about this. I would like to emphasize the importance of tumor biology. Now, RAS and REF mutations, we use it to select patients for biological treatment, but I think they are very important prognostic factors as well. And when you weigh the overall patient, I think it's important to have this information. So ideally, we should do RAS and REF mutations, even in patients whom we're going for curative intent treatment, and we're not really, other than from a sort of a therapeutic point of view, from a prognostic point of view, it will give you a lot of information. Mismatch repair deficiency and microsatellite instability, again, a very important biomarker. And I will be talking about it as we discuss the cases. So tumor biology is very important, and ideally these molecular tests should be available because there is no sort of algorithmic approach to these patients, and we need to weigh each of these factors. So the issue is, do you give chemo first or upfront surgery? As Professor Sivaganesh said, there is no standard approach. Certainly this trial, the EPOCH trial, did not show an overall survival benefit. For upfront chemotherapy, there was an advantage in progression-free survival, but no overall survival advantage. So actually, if you've got a resectable liver metastasis and a resectable primary, it is acceptable to do upfront surgery, particularly as Professor Ganesh said, if it is a colon primary that you've got and a very eminently resectable liver deposit, then certainly you could go ahead with upfront surgery. The advantage of giving upfront chemo is that you downstage the primary, number one, and number two is that you select patients a bit more. Patients with aggressive biology who progress while on chemotherapy wouldn't do well. So your patient selection is better if you give upfront chemo. Now, one important thing that I want to highlight is that you can see that at 5 years here, the progression-free survival is, even in patients who received chemotherapy, is about 30%. So meaning that 70% of patients with resectable liver metastasis would have progressed. So that's something we have to keep in mind in terms of outcomes. The issue of biologicals in this setting is debated. Now, the new EPOCH trial showed that actually when you add the biological anti-EGFR agent cetuximab, your survival is actually worse. So they thought that that might be because it switches the tumor onto a more aggressive phenotype. So if you've got resectable liver metastasis, you generally wouldn't use biologicals, even if you are going to use neoadjuvant chemotherapy. However, this is where there is a controversy in oncology. If you've got unresectable liver metastasis, then cetuximab obviously improves overall survival, and it also improves the rates of resection. So in this trial, in the Chinese trial called the BELIEF study, the use of cetuximab in unresectable liver metastasis converted nearly 26% of patients to a resectable state. So again, it's hotly debated, and so you would have to really weigh the benefits when you're offering, when you're adding biologicals in this setting. The same with bevacizumab. Again, there is an improvement in overall survival as well as an improvement in patients who underwent subsequent liver resection. These are all in patients with unresectable liver metastasis. So again, it's worth looking at the figures. It's only about 25% that would get converted to a resectable state following chemotherapy and biological therapy. So with chemotherapy alone, it's probably less than 10%. Something again that we need to keep in mind. And then there is interest in the triplet combination. Usually we give chemotherapy as a doublet, 5-FU and either oxaliplatin or irinotecan. But now there was interest in combining all three drugs, and that improved survival and also improved resectability. So we've got lots of options in terms of systemic treatment, which we will discuss as we go along with the cases. So I would hand this over to Buddhika to, yeah.
Yeah, I will be, since the time is limited, I will be presenting the cases. So we have 5 cases. Am I audible, sir?
Yeah, we can hear you.
Yeah, you can.
Right. So case number 1 is a 65-year-old male patient presented with painless rectal bleeding and tenesmus. And patient needs ASA1 and CAPE score is 100%. And digital rectal examination, there was good anal tone. Lower border of the lump was palpable at the tip of the finger. Colonoscopy, there was a circumferential lesion at the mid-rectum, and it was above the lower rectal fold, and it was extending up to the rectosigmoid junction, and no synchronous lesions. MRI pelvis revealed mid-rectal growth with involved mesorectal fascia and no lateral pelvic nodes, and biopsy moderately differentiated adenocarcinoma. And what we want to discuss is this one, and CT chest, abdomen and pelvis. This is the liver window. We can see lesion in the segment 5, and it is 2 by 2 centimeter in size, and rest of the liver parenchyma is normal and no pulmonary metastasis. In this case, we have advanced rectal lesion and single liver met. And I would like to ask from Prof, as a clinician, as a surgeon, what are your concerns and how do you set about the management of this patient?
Okay, so we've got a symptomatic mid-low rectal cancer. So with a solitary liver met. The thing about this met is just a 2 centimeter metastasis. So I think this patient, obviously from the rectal point of view, is going to need neoadjuvant radiotherapy. So with a 2 centimeter lesion like this, as we discussed earlier, you have few options. You can go for chemo first, right? And then, but following, so you go for radiotherapy of the rectum, chemo, and then attend to the liver. But being a 2 centimeter liver met, what tends to sometimes happen is if it's well, or if it responds well to chemo, you lose the met. And then you will have issues about, are you going to go, how you're going to attend to that. So one of the things I would suggest in this is actually to ablate this lesion. So you've got it's a 2 centimeter lesion, it's eminently ablatable. It's a little close to the surface, but nowadays you can inject saline or use microwave, so it can be ablated. Then go ahead with radio chemo and then surveillance. That would be my sort of strategy here.
Oncologist point of view, are there any different?
Yeah, so I think if I could, let me just get you, yeah. Could I just share a few slides on this?
Okay.
Sorry. Yeah, so I think, yeah, so I would certainly, yeah, as Professor Ganesh said, either upfront liver surgery or ablation, that would be preferred here because it's a very eminently treatable liver deposit. And if you are going to do surgery upfront, then of course, or even treatment with microwave ablation, again, timing is so we would want this, sometimes with liver surgery, practically you have issues with theater time and ICU and all that. So if you're going to do microwave ablation, that's fine. Liver surgery, liver treatment first, and then we will get on to treatment of the rectum. If you want to do liver surgery first and there is going to be a delay, then of course I would prefer to give chemotherapy. Now, this is where tumor biology is important here in this case. So I would ideally like to know the RAS and RAF mutation status. Now, RAS and RAF mutations, if they're mutant, they have a poor prognosis. It's low volume mets, so wouldn't really change management very much. But it's still good to know what we're dealing with. And in terms of deficient mismatch repair gene, that is of pivotal importance in this patient because now the sequencing of treatment. So when you talk about, so the liver is sorted, you do ablation or surgery. The rectum is a bit more complex here. So standard of care, we generally, for rectal cancers, if you've got your margin threatened, as in this case, standard of care would be long course chemoradiotherapy. But there is emerging evidence to say that total neoadjuvant chemotherapy is a more suitable option. And for this patient, when you've got liver metastasis, I think total neoadjuvant treatment is a better treatment than long course chemoradiotherapy alone, because you've already got a systemic deposit. And so what you mean by total neoadjuvant treatment is where you give the chemotherapy before surgery, along with either short course or long course radiotherapy. So we know that long course radiotherapy, you give it over 5 weeks, and short course, you just give it in 1 week. So the sequence again is not clear. Lots of trials used various protocols. Some gave chemo first, some gave radiotherapy first. And also the chemo schedule is also a bit controversial. But giving total neoadjuvant treatment will improve response rate and possibly overall survival as well. So for the patient with the locally advanced primary with liver metastasis, after treatment of the liver, I would recommend total neoadjuvant treatment followed by surgery. So there are 2 trials that discuss total neoadjuvant treatment. The Prodigy 23 trial, they used the triplet combination with the long course radiotherapy, followed by chemotherapy again. And there was the Rapido trial where they just gave short course and then gave chemo. In both these trials, Prodigy and the the Rapido trial, there was improvement in disease-free survival and metastasis-free survival. Of course, the local regional control wasn't really improved, possibly because of the study wasn't powered adequately for that endpoint. It's the same with the Rapido trial. So in this patient, you actually have lots of potential options, but I would go for liver treatment first, then chemotherapy, FOLFIRINOX, then long course chemoradiotherapy, and then chemotherapy, and then surgery to the rectum. That would be my approach. Now, where deficient mismatch repair status is important is that in patients with a deficient mismatch repair, they are not very chemosensitive, but they are radiosensitive. So if that's the case, if there's deficient mismatch repair, I would go for long course chemoradiotherapy, and then the anterior resection, and then chemotherapy. So this is where having all this biological profiling is important in an ideal setting.
Okay, sir.
There's one other thing so now that we've discussed, so the primary, attending to the primary, what I suggested was RFA. One of the things is when you have a solid treatment like this, surgery is the other option, obviously, to go up front and do surgery. But if you're going to do open surgery for this MET, and it will be a non-anatomical resection of or a metastasectomy, you end up making a fairly large incision and putting the patient through significant morbidity early on for that. Of course, if you've got the laparoscopic surgical option, then that is another strategy that you can use in these patients other than RFA. There are some who would not really like to go in as for ablation as an initial option. I'd like to ask what Rohan thinks about it. What would he do? Rohan, are you?
Yeah. So I was just following. I think if you think of surgery, I also agree with you. For a small MET, if you are thinking of open resection, you need a big resection, big incision to approach this site. So I think one either would be laparoscopic resection or ablation. Would be I will also consider that as a better option. And then
the other advantage of ablating is you have the site of the lesion where you've done it, so that even in subsequent follow-up scans, you know exactly where that lesion has been, and you can look at interval changes.
Right. Shall we move on to the second case, sir?
Yeah, that's.
This is a 58-year-old lady presented with painless rectal bleeding and sense of incomplete evacuation for 2 months duration. And patient is ASA2 and KF score is 100%. And digital rectal examination, it's good anal tone. There's growth at 6 centimeters from the anal verge with contact bleeding and could not go above the lump. Colonoscopy, it was mid to lower rectal growth, mainly posterior, lower margin at the lower rectal fold, and there was no synchronous lesions. And biopsy, it was moderately differentiated adenocarcinoma. MRI pelvis showed lower rectal growth, involved mesorectal fascia, and compared to the last case, the lateral pelvic nodes are positive, and there was no involvement of the sphincter complex and the lateral pelvic wall. And CECT abdomen, compared to the last case, there are 3 lesions, one in the segment 6 and one in the segment 5 and one in the segment 2. So all are small lesions, except segment 6 lesion is 3 centimeters. I would like to ask from Prof, compared to the last case, are there any difference in the change in the management in the surgical perspective?
Again, looking at this, these are all sub 2 centimeter lesions, except, as you said, the segment 6 one.
Yeah.
The strategy again here, I think, would be looking at they are subcapsular, but I think they should still be amenable to ablation.
Okay.
Since there are 3, I think one option would be you can still go upfront do non-anatomical metastasectomies of these three, especially I'm not very comfortable ablating a 3 centimeter lesion in segment 6.
Okay.
So you can go up front. Of course, it involves the morbidity of a liver resection, but it'll be a fairly quick one because you're looking at this. At the same time, the advantage of that is you've got bilobar disease here. And when you go and look at this intraoperatively, we have the added advantage of intraoperative ultrasonography, which may pick up some other lesions, which you may then ablate intraoperatively. So while it is something that can cause significant, or it can cause a bit of morbidity, she seems a relatively fit patient. I would probably consider going up front and ablating these, resecting these, and ablating any other lesions that are seen on intraop ultrasound, and then sending the patient over to Nurad for the rectum and systemic chemo.
I would like to ask from Nurad sir, compared to the previous case, do you consider this as a more aggressive tumor biology, considering the positive lateral pelvic nodes and 3 lesions, or is it the same as the oncological point of view?
No, certainly this case looks more aggressive. And again, I would like to know the RAS-RAF status here. If it is RAS and RAF mutant, certainly I would, of course, be more inclined to sort of go down the route of perioperative chemotherapy, because this looks a bit aggressive. And of course, it's still fine to go ahead with the upfront treatment of the liver. Also, now about liver, if you're doing an open liver, liver resection, you've got a tumor which is threatening the mesorectal fascia is threatened. There are lateral pelvic wall nodes. So, if Professor Sivaganesh can turn around this patient for me within 2 to 3 weeks, then I'll be quite happy. But I don't know what the theater times and ICU times and all that. If there are any concerns about delays, then of course, again, I would simply offer this patient some chemo, and then after about 3 months of chemotherapy, then we could go ahead with the liver surgery. I would feel a lot more comfortable knowing that this patient has got some chemo before there are delays.
Okay, if there are delays and if we decided for upfront chemo, you touched that's the total neoadjuvant previous case.
Yeah.
For instance, if we think that we give total neoadjuvant in this patient, is there a chance of disappearing the lesions, and how do you set about the management?
Yeah, so that's something for Professor Sivaganesh too. If the liver mets disappear, I think that's a concern. But generally, you would assess after about, like when you're giving it for operable tumors, 2 to 3 cycles. So you hopefully wouldn't, see a total disappearance as such. But that's a possibility. But if that's where all these RAS-RAF, all this biology is important. The molecular markers may help you sort of decide, although individually you don't really make therapeutic decisions. When you weigh everything together, that's a concern. But I'm worried about the primary. The primary looks pretty bad. Yeah. The local regional.
Preoperative radiological marking as option, Prof, what do you think in this patient?
So the radiological marking, of course, can be done by ablation. So ablation has the dual benefit of both ablating the tumor, which you can do here as well. You can ablate all these 3. That's another option. This is sort of, I suppose with microwave or a little bit of saline infiltration subcapsularly, you can ablate these 3. The segment 6 one is a little, not exactly amenable to ablation, but if you ablate it, then you've got your marker there, if you know what I mean. Nuraj, you're quite right. One of the concerns with these small sort of sub 2 or sub centimeter, 2 centimeter lesions is if you don't catch them before they disappear, or in case they disappear, then we are sort of stuck wondering, okay, where is this? What do we do with this lesion. So that is why sometimes we tend to hop in and do this. Yeah, but what you said is absolutely right. I think looking at the distribution and this upfront chemo probably addresses the micrometastasis as well, which probably will come up later on. I'd like to ask Rohan, what would you do for this? Rohan, what would yours?
Yeah, I agree with both of you, Shiva and Nurad. My little concern is the small lesions, especially on one in segment 5, and even the one in segment 2. There's a good tendency to disappear. About 1/3 will disappear if you really follow this up. All three options are correct. I think my personal thing is, if you can resect this, sort it out. This is not difficult resection, all these 3 lesions. It's very unlikely that that you end up in complication in a straightforward one like this. Unlike the previous one, I'm a bit inclined towards surgery because you are putting incision to clear 3 lesions. So I'm a bit inclined towards surgery, but I agree with Nurad that this is going to be aggressive tumor. It's aggressive tumor. So sometimes what we do is we discuss with the oncologist, and then we start chemo. And then because there's a waiting time for surgery, and then we bring them down in between the cycle, and then finish off the liver once we get the theater time, and then continue with chemo. So that's one strategy we can think of. What do you think, Murad?
Yes, it's all down to the weight. If you can sort of slot this patient in ideal world and get this, 3 to 4 weeks, if you can get this patient back after liver surgery, then certainly upfront surgery is fine. But anything more than that with the involved pelvic nodes and lateral nodes and involved mesorectal fascia, I would be a bit concerned about that. And this is a patient I would certainly give total neoadjuvant chemotherapy as far as the rectum is concerned.
Yeah.
Shall we move on to the next case, sir?
Yeah.
67-year-old male patient with loss of appetite and loss of weight for 2 months, and he had undergone a low anterior resection 1 year back, and he had refused chemoradiotherapy during first surgery, and now is ASA1 and KF 100%. Colonoscopy 6 months back was unremarkable, and now current CEA level is 115, and CT chest abdomen, this is the appearance, and there's a large lesion in the right lobe of the liver and segment 4. Segment 2 and 3 free of tumor, grade liver, and there are no lung mets. By looking at the CT, I would like to ask from Prof, is it the liver? So,
I didn't get your last, by looking at the CT, you say?
is it operable? What are your concerns?
Yeah. No, this is certainly, if you talk about in terms of it's certainly a resectable tumor, based on the images we have. Of course, if he's an averagely built person, I think even as things are, he should be able to comfortably go through. Is he diabetic? I'm sorry, I may. He says one, right? Yeah. Okay. So yes, so I think we have 2 options here. We can go for primary surgery. You see, the thing about primary, or we have the other option is neoadjuvant. Maybe downsize this and go for surgery, because you see that margin on the towards the left lateral segment is pretty close, but still that looks to me like a very comfortable, still looks like a comfortable margin. The downside of giving chemo is one of two. A, the tumor may progress through chemo. Number two, you see, we soon we'll have to wait. When you give chemo, we generally prefer to wait about at least 8 weeks before operating, because the liver, tends to show steatohepatitis. I mean, chemo-induced steatohepatosis. So I would probably, having gone through this, I may go for primary surgery, because the vessels are well away, and I mean, I'm sure the hepatic veins as you go up, are okay. So I would think of an extended right hepatectomy for this patient, and then subsequently, if necessary, chemo. And yeah.
Oncological perspective,
Yeah,
is there?
so I think this is a patient whom I would somehow, even in our setting, do a PET CT here. He's got fairly large liver metastasis, so I think we probably need to exclude extrahepatic metastasis here. And again, regarding biology, so this is a metachronous tumor, so the biology is slightly better than synchronous deposits, but of course it's within 1 year. And so again, if this was RAS/RAF mutant, again, I would, of course, I would certainly offer perioperative chemo, because this is fairly large metastasis, and if it progresses while on chemotherapy, the outcome isn't going to be good anyway. So
Yeah.
probably selected, it probably aids patient selection. If it is RAS/RAF wild type, certainly upfront surgery is an option. But if you have any concern regarding the margins, I think the safe thing is to, I mean, there is more of a sort of imperative to give chemo. So yeah, so again, biology would play a role, and I would certainly do a PET CT because this is a patient who has defaulted, and yeah. And also the question is, after resecting the liver, is a patient who has defaulted adjuvant treatment before. So if he's going to default adjuvant treatment after liver resection, I'm not really sure whether, so that's something to factor in as well from a sort of the patient, looking at patient factors. But yeah, so upfront liver surgery is an option, but chemotherapy again, I think perioperative chemotherapy might sort of help select the bad tumors out.
Yeah, I agree, Nurad. That is true. So that window between chemo and surgery is helpful in, as you said, selecting out those with bad tumor biology. Yeah. So I'm just looking at it from the surgical perspective of a tumor-free margin and residual liver volume and function. So there is the grade 1 fatty liver per se is very difficult to sort of actually quantify. I think we would go through this CT more carefully also to see how much the remnant is and decide. Yeah, so Rohan, what do you think, Rohan? Would you wait for chemo to do this, or would you like to go up front and take this out?
Yeah, I agree with Nurad. He said that it looks
aggressive,
quite big and bulky tumor. So there definitely it's going to be microscopic disease. But I have a major concern here because the amount of liver that is going to be left behind is sort of marginal. It's about 20 to 25% of the total volume, and if that remaining liver needs quite a regeneration after resection. And what I've seen is that a lot of our patients get CASH, chemo-induced steatohepatitis, and the regeneration that you get after CASH is quite poor. So on the other hand, if you give chemo, then the patient has a higher chance of going into post-operative liver dysfunction and failure. So that's a negative side of neoadjuvant. But then the positive side is, let's say, if it is a tumor that is not responding to chemo, and definitely it's going to be overall poor outcome. So both sides of it.
So, but this guy has not had chemo. Yeah? He has refused chemo.
Yeah, he has defaulted.
No,
He has defaulted.
no, what I was thinking about is neoadjuvant chemo before the liver.
Yeah. So this is my concern as well. The moment you give chemo, and if the tumor in this case, when you give chemo, and even if the tumor is stable, your liver remnant is going to regenerate and perform less well than if we didn't give chemo. So we generally say even in stable tumor, go ahead and offer surgery. So you wait 6 to 8 weeks. I mean, not about 8 to 10 weeks generally after chemo to go ahead with surgery because of this. But yet I agree with you, Rohan. That is really my concern. So I mean, surgery is not too bad because it's an extended right and the actual parenchymal transection is very relatively small. The other thing about the remnant liver in these patients is some of this tumor bulk actually has already done its job in terms of compensatory function on the remnant. So I think, I mean, it's difficult to eyeball this and say, I would say this is about maybe 25-30% even. I would, of course, taking the qualifications that Nurad has mentioned, probably err on the side of, having told the patient what these outcomes are in going for surgery first. And, the chances of post-hepatectomy liver failure and regeneration, I feel that part of it is going to be better. Tumor biology, either way, is probably not going to change very much, or the tumor factors in terms of outcome. So if you're going to offer surgery, if that's on the cards, I would still probably, that's my perspective on it. But as you said, you can work either way. It's a decision you've got to make with your oncologist and your anesthetist and so on. Yeah.
Right. Shall we move on to the next case?
Yeah, sure.
Case number 4. This is a 58-year-old male patient presented with painless rectal bleeding and blood was mixed with stools, and patient is ACA1 and KF 100%. And the digital rectal examination, there's no lumps, and colonoscopy, there's a growth at mid-sigmoid and there's no synchronous lesions. And biopsy, it's moderately differentiated adenocarcinoma. And this is the CT appearance. And the points to highlight, there are multiple focal lesions in the right lobe of the liver. And the one important lesion in the segment 8, it is measures about 5.1 into 1.7 centimeters. And it extends into the middle and left hepatic vein confluence. So this is the middle hepatic vein and this is the left hepatic vein, and it has gone into that confluence as well. No definite lesions in the segment 2 and 3 and no lung mets. Considering this aggressive and the large tumor, Prof, what do you think? Is it operable in primary setting, or do you need preoperative chemotherapy and downstaging?
Okay, so before I go to that, there's one other little thing I wanted to mention on the previous CT. That is where the large tumor in the right liver. Generally, I don't know, and this is anecdotal, I found that these very large tumors, which are confluent, which are not multiple, tend to be tend to have generally better outcomes than multiple or diffuse kind of tumors, even in colorectal cancers. I don't know what Rohan feels about it, and their margins, they tend to do better. I don't know whether there's any oncological basis for it, probably not. Rather than you having multiple, or the ones like that you just showed in this patient. So that's another reason I would probably pick primary surgery. So while everyone probably thinks I'm just, and I'm sure Nurad is convinced that this fellow is just waits to, wants to resect everything. This one I definitely hand over to you, Nurad. Yeah, this involvement of the confluence of the middle and left hepatic, I would probably put it as non-resectable. Definitely no primary surgery. Even after neoadjuvant, I would question whether we could, unless you go for some sort of major reconstructive surgery where you actually replace, you put the patient, you take off a segment of the left vein, reconstruct it, and so on, which is something with high morbidity and questionable outcomes. I would not really think about that.
What is your opinion on this patient?
Yeah, so when surgeons send us gifts, we know the biology isn't very good actually. So anyway, so this is yeah, I don't think this is sort of suitable for upfront surgery. So probably as Professor Sivaganesh said, it's probably we would have, whether it's even borderline resectable is questionable. So I would just get on with chemotherapy, and then we saw in the trials that there was a percentage that converted, but as he says, even for this patient, that probability is also quite low. So again, the prognosis isn't very good. So I would approach this more in line with an unresectable liver metastasis.
In case if we give chemo and this the follow-up CT shows there's no deposits, I mean the lesion is disappeared in the vital area in the confluence, will you still label this as a palliative case, or do you consider resection? Rohan sir, what is your opinion on this patient?
I think we'll ask Siva's opinion first.
Okay, so I'll hand over this patient to Rohan actually. No, I mean it's like this. You see, yes, even if there is tumor regression, looking at this CT, it's involving the confluence of the middle left and the hepatic, the IVC rather, and you might do surgery. The maximum you can do is an extended right, and mind you, post chemo, we don't know what state this liver is going to be in. You're putting the patient through a major procedure for a very, very questionable outcome. So if you ask me, no, I wouldn't really go for surgery here in this patient. Sorry, Rohan, over to you.
Yeah, well, I would still consider because but it will be individualized decision based on the fact that there are quite a few studies where they have looked at the scar after chemotherapy, and in these patients, 1/3 of the patients, the scar actually did not have tumor cells. So there's 1/3 possibility if this responds well to chemotherapy. There is about 33% possibility that the scar that we are resecting around the middle hepatic, the critical area here around the middle hepatic, may not contain tumor cells. So if the patient is a good surgical candidate and if everything else is fine, if the tumor responds well to chemotherapy, I still would think of offering extended right hepatectomy in this patient, depending on the case. But again, Nurad may not agree with me. What do you think?
No, yeah, Sam. I mean, after chemotherapy, if it's, I mean, if you can do surgery, then I mean, if there is a good response and if it is operable, and so that judgment is left to I think the hepatobiliary surgeon. But I think we saw from the survival data that even for resectable patients, the outcomes only about 30% remain disease-free at 5 years. And that's resectable, sort of very resectable cases. So we might be sort of looking at a poor prognostic tumor, and outcomes may not be great. So again, we have to see weigh the complications of an extended surgery in this setting. So, but if there is stable disease and we've got, I mean, we've given chemotherapy and it has responded, if you're able to do surgery, I would certainly not stop anyone doing it.
Okay. Do we have time for the next case? So shall we?
I'm happy to just, we've got, another 5 minutes. And
Okay. Right. Case number 5, 75-year-old lady presented with 6 months history of rectal bleeding and left-sided abdominal pain. And there's no lumps in the digital rectal examination. Colonoscopy, growth at rectosigmoid junction. Scope could not negotiated. Biopsy, moderately differentiated adenocarcinoma. And this is the CT. There are multiple hypoenhancing in all the, and there's a little area of the parenchyma is spared, but the segment 4A is touching by this lesion. And for the surgeon's perspective, is there a place for resection?
Okay, so here definitely not liver first.
Okay.
I don't think so. She's got an obstructing obstructing rectosigmoid, isn't it? It's or
Yes.
impending obstruction. So I think that the priority here is to get the primary out.
Okay.
I would probably get the primary out, and then she's 75. I don't know whether she's that also depends how good or bad a 75 is. And now, having listened to a lot of the other things that Norad had to say, maybe look at tumor biology as well. Decide on the liver. Now, if you're talking about in the context of, let's say, good tumor biology that responds well to chemo, then we will have to see what the response after chemo is. Fit 75. You may then consider, this looks like one of the potential cases where you might do a 2-stage hepatectomy, provided all goes well between taking the primary out and after chemo.
Oncology point of view, what do you think, sir?
Yeah, so this is a sort of a 75-year-old patient. Now, these patients really, I mean, even the fit ones, when you talk of chemotherapy, we give the doublet combinations. We have to reduce doses, and it's not an easy journey. So I'm just wondering whether, this 2-stage liver resection, this amount of extensive meds, again, looking at survival data and so on. This is a patient who has waited for 6 months. So again, if you're thinking of curative intent, again, I would do a PET CT scan here. And I'm probably being swayed to the side of sort of palliation here, palliative sort of treatment. I would certainly, the primary looks a concern. And as Professor Vagani said, even though the liver may not be resectable, I would still operate on the primary from a symptomatic point of view. And then chemotherapy, the 75, as Professor Sivaganesh said, there's a range in 75. There could be a 75, but generally these patients don't tolerate combination chemotherapy very well. So I might just give a single agent chemo and sort of go down the route of, palliative, life prolonging treatment rather than, I think a 2-stage liver resection, everything might be a bit too ambitious.
No, I agree with you. That's absolutely right. I think I'm just really pushing the boundaries here to sort of say what the potential. But if you take the context, as you said, the person at 75, probably you're not going to go down that road. And with the inherent problems that you say, you would have with chemo. So, but let's say this was, if you flip the coin and said that this was a, maybe a 55 or 60 fit person, otherwise, that sort of would be the approach where you would see how the response to chemo is, and then decide on, because it's bilocal, is whether we can consider. But yeah, in this 75-year, definitely, I agree with you.
Right. So that's for the cases. We have some questions from the audience. Chamal Fernando, what if the liver met disappear after neoadjuvant chemo? We answered that question, so we can skip that. How common is the chemo-induced hepatitis CASH in our patients? From Nuraj, sir.
Yeah, so obviously in patients not going for liver resection, we don't, it's not a major concern for us. So we give these chemotherapy agents quite routinely, but I think, I think the patients who undergo liver resection, we would have to look at that data. From the discussion, I feel that quite a lot of them have undergone upfront surgery. So
Okay.
we probably wouldn't know the real incidence, but with oxaliplatin, there is this concern of veno-occlusive disease, and with irinotecan, you have steatohepatitis. It's well documented, and certainly that's why for operable tumors, you wouldn't give more than 3 to 4 cycles of chemo. But yes, that is a concern. But regarding the time interval, if anti-vascular endothelial growth factor agents are not used, generally it's possible to do it within about 3 to 4 weeks. But I don't know, obviously our incidence of fatty liver in our setting is probably different to the West, so we can't really extrapolate. But the concerns about it are certainly valid.
What are the advantages and disadvantages of anatomical versus non-anatomical resections? Must be in the setting of colorectal liver, I think.
So the advantage of
the
advantages of non-anatomical resection is it helps to spare parenchyma. And if you've got bilobar disease, what you then in the past if you were doing formal resections, and you're basically left with unresectable disease. So whenever we think of malignancies in general, we've got to look at two things. One, especially in terms of the liver, you need to get all your tumor out, so it should be oncologically safe. And B, you're looking at in terms of the liver, the residual liver function. So the advantage of non-anatomical resections is you're able to, and it has been clearly shown that it is not inferior in terms of oncological outcomes. And you've got you're able to convert what is a potentially unresectable liver to a resectable one. You've got less physiological derangement because you're leaving more liver remnant. Having said that, the disadvantage, of course, is paradoxically, your non-anatomical resections and multiple metastasectomies can be more complex than doing a standard right hepatectomy or a left hepatectomy, where you just have one transection plane and you go down. And especially when they are deep lesions, it can be quite challenging to do non-anatomical or metastasectomy. So those are the pros and cons of it. But there is an increasing realization and trend towards parenchymal sparing surgery. The reason it was not done in the past was there was concern about oncological outcomes, but these have been allayed by now.
Right. Do you need a liver biopsy if you are thinking of adjuvant treatment for the liver? Do you think liver biopsy would help?
So in terms of before neoadjuvant treatment, is it?
Should be, I think.
We might do a biopsy. The only setting that is, so if it's a metachronous tumor and you want to know the RAS-RAF status, you're thinking of biologicals and so on, then we might need to do a biopsy in that setting. We might also need to do a biopsy if there is some concern about whether it's a deposit or not. But I wouldn't, I mean, if it is confirmed to be a metastasis and you don't need information on the biology, I wouldn't really, it's probably not needed. Having said that, if you're doing ablation, and I mean, you can have variant tumor biology. So I don't know whether when you're doing microwave ablation and so on, whether it's possible to do a biopsy first or whether that impacts on the treatment or anything. But certainly in that setting we might do, but solely for the purpose of giving chemotherapy, we wouldn't really, it's not needed if your metastasis is confirmed.
Okay, sir. Is it the same chemotherapeutic agents that will give that we are giving for the downstage, the liver mets and the rectal carcinoma?
Yeah, so if you've got metastatic disease, if it's a resectable liver mets, if you got resectable liver mets, then we would give the same kind of chemo, FOLFOX. But if you are looking at conversion, then there is, and you want to give the triplet combination. Sometimes you would want to give the triplet combination. You give, so there are basically 3 drugs: 5-FU, oxaliplatin, and irinotecan. So in the curative setting, we use 5-FU and oxaliplatin. But you can use all 3 drugs if you want a better response. And certainly with the total neoadjuvant approach, the Prodigy trial, they used all 3 drugs. So it's basically the same combinations.
Okay. Even though the primary is not locally advanced, if there is a resectable liver met, is there an indication for neoadjuvant therapy?
Yeah, so I think if the primary and the liver is both resectable, then the thing to do would be to go for upfront resection. Unless you have some other concerns. So if both are resectable, then I think upfront surgery is preferred.
Okay, sir. Buddhu Jamaha is raising hand. You can unmute and ask the question.
I have already asked the 2 questions, sir. I have got the answers.
All right. Okay. Thank you.
Thank you.
There is in the question and answer panel, there is a question somebody asked. The last case, if we don't operate the liver in this 75-year-old, would we rather do a defunctioning stoma instead of resecting the primary? That's a very good question, actually. So we've just discussed this. I think that last patient who had bilobar liver, right? Yeah. And we said the primary has to be done because this was a near obstructing rectosigmoid tumor. And that's a good question. Do we need to resect the primary, or can you just do a defunctioning stoma? I would still resect that primary for 2 reasons. A, it can, there is a potential for the tumor to advance locally, and that can cause other symptoms like bleeding. It can cause lateral pelvic wall involvement or neural or ureters or whatever. So taking the primary out is useful because these patients can, and as Nurad might say, sometimes if the tumor biology is good and the patient responds, they can have a fairly good period of survival, even if you don't do a liver resection. So I would take out the primary rather than just leave a defunctioning stoma. However, that depends on the patient. If your patient is a high-risk patient for surgery, and then you're going to put them through, the colonic resection, then probably not. I want to ask Nurad, is there some evidence to say that actually resecting the primary in even metastatic disease has a slight improvement in outcome? I remember it is somewhere, someplace.
No, there is no advantage if it is. Yeah. So but for symptomatic, for symptomatic relief, certainly a stoma might be quality of life for this 75-year-old patient might not be good. If the patient is not very fit, I am wondering whether it's at the rectosigmoid junction. What about stenting? Is that?
Stenting is an option. Yeah.
Okay.
Right. From the panel, there's one question. How is the waiting list for ablation in Sri Lanka? Probably asking radio frequency or microwave ablation.
There is no real waiting list as such. So when the patients come in, we are able to get, so it depends on what you mean. If you're talking about intraoperative ablation, of course, you talk to the radiologist and they'll come and, we do it with them during surgery. I can only speak for NHSL, and we generally are able to talk to our radiologists and expedite it. So, okay, we are looking at probably 2 weeks to 4 weeks, maybe 2 weeks, probably, if you really push them.
Okay. One question, what are the available options to predict post liver resection, morbidity and mortality?
I think you're probably talking mainly in terms of post-hepatectomy liver failure.
Yeah.
I think that's probably what the question is. And the outcomes, as we discussed earlier, it depends on the quality and the quantity of the remnant liver. Of course, there are other perioperative factors such as the duration of surgery, blood loss, and transfusion requirement. Those are some of the other things that actually relate to post-hepatectomy liver failure. Diabetes is another thing, liver regenerative capacity in diabetes is slightly less. And of course, as we discussed earlier, preoperative chemo can also, or neoadjuvant chemo can also impact outcomes. And we generally, I prefer to wait about 8 to 10 weeks after chemo, at least before operating on these livers. I don't know how long what Rohan feels about it, but that's the general duration we would wait at least before operating.
I think that's all we have.
So I think we have come to the end of our meeting. So I think we had a very fruitful meeting, this important topic, and this meeting actually was done in collaboration with the Sri Lanka Society of Sri Lanka College of Oncologists. So on behalf of our society, the Sri Lanka Society of Gastroenterology, I would like to extend our gratitude to Dr. A.J. Hilmi, who's the president of the College of Oncologists, and also Dr. Nurad, who joined us on behalf of their college. Thank you very much, Nurad. And from the surgical perspective, Professor Siva Ganesh joined us and gave his expertise to this topic. So I would like to thank him as well on behalf of the Sri Lanka Society of Gastroenterology. Thank you, Professor Siva Ganesh. So thank you both, and I think we are going to wind up our session today. Thank you.
Okay.
And thank you, Buddhika, as well, for presenting.
I learned a lot. Thank you.
Same here, and Buddhika's cases were excellent. So thank you, Buddhika, for those very interesting cases.
Thank you, sir.
Okay. Good night.
Thank you. Good night.